inherited bleeding disorders, the last guideline. So the disorders which are commonly, there are many disorders that they've given, but mostly you get questions from hemophilia or von Willebrand disease. So these are the ones which I've covered. Okay. So hemophilia. About hemophilia, what do you know? What kind of inheritance it is?
X-linked.
Yes, it is X-linked. It is X-linked recessive. The inheritance is X-linked recessive, and there is hemophilia A and hemophilia B. Hemophilia A is if there is deficiency of factor 8. Hemophilia B is deficiency of factor 9. Okay. Since it's X-linked recessive, so usually the females are the carrier, and it is a male who carries the disease. Okay.
Yeah.
Okay, so up to 50% of neonatal males with severe hemophilia have no previous family history because females are the carriers. Okay, in these cases, there is a 90% chance that the mother is a carrier with risk to the next male child also. And if there is hemophilia A, then you have to see factor 8 is to von Willebrand ratio. If that ratio is less than 0.7, it is suggestive of carriership, but the ratio more than 7 does not exclude it.
Yeah. Can you please repeat it once about the inheritance?
About since it's X-linked recessive, so if the mother is a carrier, okay, right? So if it's a male baby, what is the chance of the of developing a male baby? It is 50%, right?
Yeah.
For any pregnancy, chances of male is 50%, chances of female is 50%, right?
Okay.
If mother is the carrier, father is normal. Okay, then the male child will receive X chromosome from the mother and Y chromosome from the father, right?
Yeah.
Okay, one pair from the mother and only that's why it will be male, no? Y from the father. So one of the X is normal and one of the X is having the defective gene. Okay, so so in that case, the chance of having an if it's a male child, then chance of having an affected male will be 50%. Understood? Because one will be having a normal X gene from the mother, one will be having a defective gene from the mother, and because they do not have another normal X gene to mask that defective X gene, they have a Y rather, right? So they will express the disease.
Yeah.
Okay, is it clear?
Yeah. Okay.
So see, mother will have, if mother is a carrier, okay, mother will have X dash is the defective gene, X is the normal gene, okay. Father will have XY, right? So now what are the chances of the baby? Okay, baby can be, baby can receive XX and XX, okay. Then it can be XY, right? Or it can be XY, or it can be um, XX, right?
It can be XX, it can be X5. Yeah, X5. Okay.
Okay, so in this, these are the male babies, right? And the other two white one are the female babies. Okay, so female will only be the carrier. Okay,
Yeah.
because only one defective gene. In case of male, this male will be normal, so there are 50% chance. Okay, so two chance, there are 50% chance that the male will be affected because if the male is having only one defective gene X, it doesn't have a normal X to balance it. So this male will be having hemophilia. So this male will be affected with hemophilia.
Okay.
Okay.
In a male child, there is a chance of 50% being affected.
Yes. Overall, there is 25% chance of a baby being affected. But if they ask you, they will never ask you like this in case of X-linked disorders. Ki what percent of the child? They'll ask what percent of the male child will be affected. So it will be 50%, right? There are two. Okay. Understood?
50%. Yeah, yes, ma'am.
Okay. Yeah. Then, okay. So in these cases, there is 90% chance, this I've told you. Then about the inheritance, hemophilia is X-linked recessive. Von Willebrand disease, it can be a multifactorial, autosomal dominant or autosomal recessive. So it has variable inheritance. Okay. Then there is
Okay.
another factor 11 deficiency, not very common. So it can be again autosomal dominant, autosomal recessive. Okay. Then
Okay.
coming over to severity of hemophilia, it depends on how much concentration of the factor do you have. So if it's mild, then you have zero point zero 0.06 to zero point 0.4 international units. So this is mild deficiency. If it is less than zero point zero 0.05, zero point zero 0.01 to zero point zero 0.05, it is moderate. And if it is the factor level is less than zero point zero 0.01, it is severe deficiency. Okay.
Okay.
Then how do you manage? Pre-pregnancy management. You have to do the baseline level because you have to classify whether it is mild, moderate, severe. Then you have to know the status of the partner also, because if the partner is affected, then accordingly there will be inheritance, right?
Yeah.
Yeah. So you have to do the genetic testing and the partner testing. Then about the and
Okay.
this is about the pre-pregnancy management. Then antenatal management. So if there is severe hemophilia, if the patient has severe hemophilia, then you have to do a pre-implantation genetic diagnosis. One, you should, why? Because you have to check out the sex of the baby. If the mother is having severe hemophilia, then there are chances that 50% of the male baby will be affected. So you can offer for sex selection. Also for the baby, you can offer genetic this thing. You can CVS, you can offer CVS or amniocentesis to find out whether the baby has hemophilia or not. Okay. So this can be offered.
Okay.
Then how do you manage? So in management, you should remember, like, you have to keep the factor level, well, at least zero point 0.5. Okay. But if the factor level goes less than zero point 0.5, you have to treat the patient. How do you treat? You give the factor. Okay.
Okay.
If there is fact, basically these are clotting factors. If they are deficient, what will happen? There will be risk of bleeding. Okay.
Mm-hmm.
And with
Okay.
factor 8, it is
And
also
why
cancer.
ma'am,
Hmm?
sex selection is done prior to conception. I mean, when it is done,
It can be
like
done in
what do we do?
It can be done in X-linked recessive disorder. It is allowed by the government for this, for X-linked
Okay.
recessive disorders, because we have, there are risks that the baby can be affected. No, so in these disorders, it is allowed.
So we terminate the pregnancy.
Yeah.
Okay.
Okay.
Okay, ma'am.
So this was
Okay.
about the genetic part. Then about the actual management. If the patient has severe hemophilia, that is the factor concentration is less than zero point zero 0.01. Okay. So basically, if the patient has hemophilia, your target should be to maintain the factor level. Always factor level should be more than zero point 0.5. Okay.
Okay.
Whenever it goes less than that, you have to correct, because there'll be risk of bleeding in these patients. Okay, you have to avoid bleeding. Okay, you correct. If it's a factor 8 deficiency, you have to remember you give desmopressin. And in both cases, to in order to prevent the bleeding, whenever there is high risk of bleeding, you give tranexamic acid. Okay, so you give the factor, you give
For
if
that,
it,
we are giving desmopressin.
you give for
And
philia A, you give
then
desmopressin, and you if required, you give the recombinant factors. Okay,
okay.
and till what time do you replace? Till the level becomes more than 1. Okay, till the factor level becomes more than 1. Okay, so
Phenolic
you,
acid we are giving them for both the factors.
sorry,
Phenolic acid we are giving for both the factors in general.
In general, yes, because this though you in any form of hemophilia, wherever there is risk of bleeding, you give tranexamic acid. Okay, in order to avoid bleed.
Factor
In
factor 8.
the targeted management will be replacing the factor. So one, if it's hemophilia A, where there is factor 8 deficiency, factor 8 is also a carrier for von Willebrand disease. uh, okay, von Willebrand factor. So you, if you give you give this von Willebrand factor in the form of desmopressin. Okay, because it also
Okay.
carry, it is desmopressin is basically it acts to raise the levels of factor 8. So this you can give, or you can give recombinant factor. Okay, so this is this option you have in factor 8 deficiency only. And in desmopressin, it has an anti-diuretic effect. It causes fluid retention. So when you're giving desmopressin, you have to give strict instruction that total fluid intake should be restricted to only 1 liter in 24 hours. Again, this is a question.
Okay.
Okay, and for factor 9,
It will cause
hmm?
will it cause volume overload?
Yes, because it has anti-diuretic effect.
Okay, okay, ma'am.
Okay. And when giving treatment to raise the clotting factor levels, it is important to monitor response to treatment by measuring the plasma clotting factor concentration before and after infusion and 4 to 6 hours following treatment to facilitate the dosing. Okay, understood. So can you tell me, like, if the fact when what will be the when will you treat this patient of hemophilia? What should be the target level to initiate treatment?
0.5. We should main when it is
Less than zero point 0.5, yes. And what will we give if it's a factor 8 hemophilia A? What will you give? How will you treat?
yeah, we give desmopressin.
Yes. And what desmopressin? What are the other options that you can give?
Other option is recombinant factor 8.
And
If it's not
what else do you give?
in general, tranamic acid.
Tranexamic acid, yes. Until when do you replace? Like, what should be your target? At the factor level reaches when? After that, you will stop.
0.5.
No, 1. So you go beyond zero point
Oh,
0.5. Okay, so treatment, if that you are giving the treatment, you should continue it till it reaches 1.
okay. Okay,
Okay.
so we are starting when it goes less than 0.5, or when it comes to 0.5, we are starting. I
Mm,
mean, we are giving, and it should our target is 1.
yes. Yes. And desmopressin,
Okay,
what specific instruction will you give the patient? Like what's
and there should there should be fluid retention. I mean, restricted to 1 liter per day,
in, yes, 1 liter in
as it's
yeah. So this was about intrapartum management. If it's a male baby, because there the chances of the baby being affected, it should be MDT team should be involved. Then you will avoid all this where like there can be bleeding in the baby. Okay, so ECV should be avoided, ventouse delivery, mid cavity forceps, fetal blood sampling, fetal scalp electrode monitoring. All this should be avoided. And this, if the
okay.
baby status is not known, then you plan cesarean section. You do not go for normal delivery. You plan a cesarean section at 39 weeks if it's a male and the status of the baby is not known. And factor 8 and 9 levels of more than zero point 0.5 are required for insertion or removal of epidural catheter and for spinal. So zero point 0.5 is something which you should remember. That should be your target to maintain. Okay.
And why for cesarean, ma'am, if it is male?
Because like in normal delivery there can be head trauma and all that, no, if the baby gets stuck, because you cannot do
Okay.
all these things, no, you cannot put forceps, you cannot do ventouse delivery. So you
Yeah, on
do
the
a,
safer side. Okay.
yeah. For postnatal management, active management of third stage of labor should be done to avoid bleeding. Factor 8 and 9 levels should be maintained above zero point 0.5 for at least 3 days following an uncomplicated vaginal delivery or 5 days following an instrumental delivery or cesarean section. Tranexamic acid should be continued in the postpartum period until the lochia is minimal. Pharmacological thromboprofile. In this cases, you are not giving thromboprophylaxis because anyways they are at a high risk of bleeding, and if you give thromboprophylaxis, again low molecular weight heparin can cause more bleeding, so you do not give thromboprophylaxis. Okay, rather you give
Okay.
mechanical stockings or mechanical methods you use basically. Should be avoided where the factor level is less than zero point 0.6. Okay. Then this was about the postnatal management. Then about the management of the baby. So you have to do because you have to diagnose whether the male baby is affected or not. Then you have to do a cord blood sampling and diagnostic testing to see whether the baby is affected or not. Some mild cases may require retesting at 3 to 6 months of age. In a in a neonate with low factor levels, then vitamin K should be given. And in order to rule out bleeding, cranial ultrasound should be done if it's a severe or
Okay.
moderate failure. And if required, if the baby has signs, then you have to do a cranial MRI as well. Okay.
Signs of okay.
Intracranial hemorrhage.
If, okay. Okay.
Okay, then you have to do a cranial MRI also. Then about
I know
one.
the ultrasound is normal.
Hmm.
What will be the sign of intracranial hemorrhage? How will we get to know?
If the patient has a focal, baby is excessively irritable, baby is crying,
Okay.
or if there is any focal
Okay.
neurological deficits,
Okay. Okay.
baby is not moving one of the limbs.
Okay.
Then about the last topic, von Willebrand disease. So there are three types of von Willebrand disease: type 1, type 2, and type 3. So type 1 is autosomal dominant, and autosomal dominant one is the one which is less severe. So it is partial quantitative where the factor activity is less than 0.3. Then type 2 is autosomal recessive, autosomal dominant. It is qualitative and it is divided into 2A, 2B, 2M, 2N. 2A is severe loss in von Willebrand factor. 2B is increased binding to GP1B. Okay, just remember that the most severe is type 3, which is autosomal recessive. Type 1 is least severe. Okay, which is autosomal dominant. Type 2 can be both autosomal
Okay.
dominant and recessive based on
How
what
about
it.
the separate quantitative and quantitative?
Qualitative is where the factor levels are okay, but it is not functioning properly because it requires certain proteins to function. Von Willebrand factors, it required this GP glycoprotein, platelet glycoprotein 1B and 2A to function. So if there are defective, the factor concentration is normal, but these proteins are defective. So then it will be qualitative. Quantitative is if the value of the factor itself is less.
Okay.
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 Then you should remember type 3, which is autosomal recessive, is the most severe. Type 1 is least severe, it is autosomal dominant. Type 2 is in between and it can be both autosomal dominant or recessive. Okay. Okay, so patients with bleeding history and von Willebrand factor activity of 0.3 to 0.5 should be regarded as low von Willebrand factor or rather than von Willebrand disease. So to classify as von Willebrand disease, the level should be less than 0.3. If it is between 0.3 to 0.5, it is called as low von Willebrand factor. Okay.
Okay.
Then how do you manage? So again, antenatal, it should be under multidisciplinary team with hematologist, uh, involvement, then you have to check the von Willebrand factor levels, and also factor 8 levels should be checked at booking in third trimester and prior to any invasive procedure. Aim should be here also, you have to maintain the level above zero point 0.5. Okay. And if it drops
Okay.
beyond that, what do you give? Same like hemophilia, you give desmopressin. And when once you're giving desmopressin, what instruction will you give?
We have a fluid retention
Fluid restriction. Yes.
up to fluid restriction 1 liter per day.
Yes, and you have to concentrate. You can give concentrates of factor 8 and von Willebrand factor also if desmopressin is not working. And your target till when will you replace till the level
It
reaches 1. So this is same. Okay. So how will you treat von Willebrand if the factor, when will you treat? What should be the uh, target for
same
initiating?
when it 0.5.
If it is less, what will you give?
We give same desmopressin or recombinant factor 8
Factor 8 or von Willebrand factor, or and tranexamic acid will go here as well. Until when will you replace?
until it reaches 1.
Yes. Then during the delivery, the timing of the treatment should be as near to the delivery as possible. Pre and post treatment levels of von Willebrand factor activity and factor 8 levels should be measured and repeated after delivery, or if the labor is prolonged, tranexamic acid should be given if the factor level is less than 0.5. Platelet transfusion as well as von Willebrand factor may be required in severe forms. For fetuses at risk of having type 2 or type 3, so these are the severe ones, you avoid all these things: fetal blood sampling, external cephalic version, fetal scalp electrode monitoring, mantoux delivery, or mid cavity forceps, because then again there is risk of bleeding. Okay. And once the baby is delivered, you will have to do a cranial ultrasound to see if there is any intracranial hemorrhage. If required, you do an MRI also. Okay, so this is same. So this was,
Almost the same.
yeah. So this was about inherited bleeding disorder and hemoglobinopathies. Any doubts?
Ma'am, can you please explain me once again that inheritance
Inheritance of what?
of
This,
this thing, hemophilia?
okay, hemophilia. I'll just.
Yeah.
So hemophilia, hemophilia is X-linked recessive, right?
Okay.
So if it is X-linked recessive, so in all these cases, usually mother is a carrier, and it is the male child which is affected. So if the mother is a carrier, so X dash is the defective gene, X is the normal gene. So one is defective, one is normal, right?
Yeah.
And and if the male is normal, then it is XY, right?
That's why.
Then chances of the baby having the disease. Okay, so what all combinations can occur in this case?
In XY, X is affected because mother is the carrier. So there are 50% chances if it is a male. Okay.
Yes,
And if it is a female child, she has two X, right? One is dominant, the other one is from her father. So,
there are 50% chance that she'll be carrier because female is this X dash X or XX. 50% chance that she'll be a carrier, she'll not be affected. Okay.
okay. So there is a 50% chance only. She can be either she'll be only a carrier or she can be a carrier also.
She can be a carrier
She
only, she
can
can
be.
have a disease. If suppose the other thing is like if she is the carrier and also the partner has the disease, okay, then what are the combinations that can occur?
No, no, like if this female is having two eggs, one from mother and the other from father, how do we know which is her dominant gene and which is recessive?
N- One is defective, one is normal. It is not a dominant or recessive one. One is abnormal gene,
So
one is
one,
not. Yeah.
so that abnormal will be from her mother only.
Yes, because only mother is having an abnormal gene. Father is normal.
Okay. So father is normal, mother is a carrier, so that mother X is affected.
Hmm.
The X
Yeah.
which is inherited from her mother is affected.
Yeah.
So when the male is affected, like there is a 50% chance for the male to be affected. Why not in this female?
Because female will
Because
get one X from the mother and one X from the father. So father X is
the
normal,
other X,
right? So then, since
yeah,
for
okay,
autosomal recessive disease to express, both the genes should be defected. Okay.
okay, okay, okay,
But
okay,
since
okay,
in
okay.
males we do not have another X, so that's why they will be expressing.
Oh, okay, it is basically X-linked recessive. Okay.
Yes, yes, yes. Then,
Yeah,
if
yes, ma'am, yes, ma'am.
the mother is the carrier and father is having the disease, then what is a chance that the mother will, the male child will be affected? And what is a chance that the
If
female will
mother
be affected?
No, if mother is a carrier and father is having a disease,
Then what is
hmm,
the chance? Yes, what is a chance that the females will be, how many will be carriers? How many will be having the disease? How many females will be having the disease? How many males will be having the disease? Hmm?
in this case, like how come like if male is affected,
Which
then
case?
both females and males both will be affected, no?
In second case,
Yeah, in second case, female child will also be affected.
yes.
She
So
will
what?
not be a carrier. But
So what?
50%.
50% females will be affected and 50% will be carriers.
Yeah, 50% they will be affected and 50% carrier.
Yeah.
In the
And
other case, when father is normal and mother is a carrier,
then only 50% chance that the female child will be the
they
carrier.
only they are not affected. They are only carrier because
Yes.
their Y is normal there.
Yes.
And in case of mother is a carrier and father is affected, male child, male
So
child, he is also affected. They can be, they are affected. No, 50% they are affected.
50% are affected, 50% are normal.
How normal? Because father is affected, they are inheriting that affected Y gene.
Y gene, it is X linked, no? It is not Y linked.
Oh
Y,
yeah, 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 yeah. I'm forgetting.
yeah.
Yeah, yes, ma'am.
Mhm. So if father
Actually,
is,
genetics. No, for part one, I prepared very well for exam.
you can
In
revise.
fact, I did all my genetics questions. I did very well. I still remember. Okay, because I was focusing so much on these. I was solving repeatedly like so many genetic questions. After the part one, forgetting the things basic.
No issues. It is easy only. You try, and they don't ask many questions on genetics. It is just for understanding.
Yeah.
In part two,
Okay,
they
got
don't
it.
ask many questions on genetics. Okay. So if
Okay.
now tell me, if the mother is a carrier, father is normal, what percent of the males will be affected? What percent of the females will be carrier? And what percent of the females will be affected?
Mother is carrier and father is normal.
Hmm.
When mother is carrier, father is normal. Females are only carrier.
Okay, what percentage of the females will be carrier? Will all the
50%.
yes, 50% will be carrier. Yeah,
Or
and
50% will get, and the other 50% will be unaffected. They will be
yeah,
normal.
yes. And what about
Okay.
the
Whereas
males?
child, whereas in case of male child, 50% will be affected.
50% will be affected and 50% will be
How normal? All will be affected only.
no, no.
No, because linked. Because this is X-linked. So 50% affected, 50% normal.
Yes, 50% will be normal. If mother is a carrier and father is affected, then what percentage will of the females will be affected? What percentage will be carriers?
Mother is carrier and father is affected. In this case, father is affected means the females are 50% affected.
Hmm.
They will be affected only. Yeah,
So
50% affected, 50% carrier. They will be affected only.
no, they
It is X-linked.
so they will be one X
Yeah,
is
50% will. What next from? So 50% carrier, 50% affected.
yes, and about
Yeah,
the
got is a
got
carrier and father is not. 50% of female child is affected and 50 are carrier.
yeah,
50 are normal and 50 are carrier. If in case, if in this scenario, when mom is a carrier and father is affected, 50% of female child are affected and the other 50 carrier.
yes, and about
I
the male.
think about the male, in case of in the first scenario, okay, mom is a carrier and father is normal.
Mm,
Males are 50% affected,
yeah,
50% affected, and the other 50 normal.
mm,
Actually, it is applicable to same only, no?
it is same only. Yes, for both the cases,
It
it
is
is
same only.
yeah.
Mm-mm. Okay. Yeah, got it.
Okay. Any other doubts?
Yeah, thank you so much.
Okay. I'll share. I've already shared the PPT. No.
Yes, ma'am. Yeah, got